I should thank my colleague Raj Rajan. I think he has been doing all groundwork for every meeting. He takes pain in arranging the speakers as well as the panelists. I should thank first Raj. Please, it's a very, it's a very friendly manner you are doing things in the last few months because I was involved in some personal work, and I must thank you for this. Though it's a shared responsibility, you take the entire responsibility for this. I know the pain of arranging finding a panelist and speakers. And this time also you have, the two speakers which are going to deliver the talk, which is going to be very significant in our clinical practice. With this introduction, so today we have two presenters. One, Dharaniya. She's a third year DNB student under Dr. Ranjini Muthu at Grims Road Apollo Hospital. She's going to present a case of surgical importance. That's why we have roped in Dr. Deepak Raghavan, who is a senior urologist at Apollo Hospital who was involved in the surgery. And the another topic is going to be presented by Dr. Arun Kumar. I would always call Arun Kumar. Whenever we don't have any cases in the presentation, we can always reach out to him. He will have a repertoire of cases and he can pull out one from that and he can present. He's already has presented 2 or 3 times on this platform. The last presentation was very impressive. He was talking about ABN compatible transplant, wherein he was talking about avoidance of plasmapheresis using only the donor plasma as a protocol. That worked well in our cases also. So thanks Arun for your and this time also he's going to bring the topic itself is very long lengthy heading is given. I could not decipher initially I just tried to figure out what you are going to talk after reading 2 to 3 times, and probably you have something in store to today. And we have a beautiful 3 panelists, and Dr. Umapati Hegde already he has chatted here as a panelist for the last 2 or 3 sessions on this platform, and today I think he's in Delhi right now. He's joining from there. He's a chairman for Muljibai Hospital, Nadiyad. And also he's a great academician, and he's a DNB teacher. Thank you, sir, for once again accepting this.
Thanks for the opportunity, sir.
Here. And the another madam is Dhanapriya. I don't know much about her from the last meeting in a state conference. She was a principal discussant of CPC, and her presentation was very impressive. She synthesized a differential diagnosis in a very beautiful way. That was one attraction I got into her after that. So she's now a senior assistant professor at Rayapeta Hospital, Chennai. Ma'am, thanks for coming here today. And Deepak Raghavan is a senior urologist and a robotic surgeon at Apollo Hospital, Grims, Chennai. And also Ranjini Muthu, ma'am, she's going to be acting as a mentorship today to her student. Ma'am is she's a WIN member, and she's a great academician and a very active person in all kind of nephrology field. So, and I'm happy to be inviting her again to this as a mentor to her student. With this introduction,
thank you, sir, for the kind words.
We are going to start with your Dharaniya. Are you ready?
Yes, sir.
So, could you please share your slides?
Yes, sir.
Okay. So, I just
one second.
Yeah. Yeah, you're visible. You can go ahead.
Yeah. Good evening, everyone. Thank you for this opportunity. I am Dharaniya, third year nephrology register. I am going to be presenting about a late surgical complication in a post-transplant patient. Small background history about the patient. He is a 39 years old male. He was detected to have CKD in 2014 when he was 28 years of age. At that time, his creatinine was 2, and he underwent a renal biopsy, which was suggestive of IgA nephropathy. He was initially treated with oral steroids for about 2 to 3 months, after which he was subsequently lost to follow-up, and we have no further records. In 2019, again, he was admitted with large pericardial effusion, which was exudative. Serum creatinine was 20 milligram per deciliter at the time, and therefore it was considered to be uremic pericarditis, and he was initiated on hemodialysis. Since he had no prospective live-related donors, he was posted for deceased donor transplantation. So PRA screening was negative. Dialysis vintage was 5 years. and he underwent a deceased donor renal transplantation on 15th of November 2024. The donor is a 51 years old male. He had no comorbidities. His serum creatinine was 0.8. It went up to 1.8 during hospital admission. His urine showed nil protein, nil RBCs, and nil pus cells. Cause of death was RTA. We received the left kidney, which was 9 cross 4 centimeter, with a single renal artery with an aortic patch, single renal vein with IVC cuff, and a single ureter. The CDC without DTT was weakly positive, but after treating with DTT, it was negative. So it was considered negative, and DSA was negative for both HLA class 1 and class 2. Since it was biopsy proven IgA nephropathy and the patient had a weakly positive CDC, ANA, ANCA, and dsDNA were done, and in which PNCA was positive with an elevated anti-MPO titers. But he had clinically no evidence of vasculitis, so we proceeded with the transplant. So he underwent deceased donor ABO compatible transplant on 15th of November 2024. The total ischemia time was about 5 hours and 2 minutes. The weight of the patient was 42 kilogram. The donor renal vein was anastomosed to the right external iliac vein, which was an end-to-side anastomosis, and donor renal artery was anastomosed to the internal iliac artery, which was end-to-end anastomosis. DJ stent was placed, and there was also a drain. There was sluggish intraoperative output for a few hours, which later picked up. He received about 40 milligram of IV Lasix initially, after which no further Lasix was given even in the immediate post-operative period. This graph outlines his immediate post-operative course. He received ATG 50 milligram for induction. 25 milligram was given on POD 0 and 25 milligram on POD 1. Total IV steroids of 1750 milligram was given over 3 days, following which he was started on tablet Visalone 30 milligram once a day. Initially, he was started on tacrolimus 2 milligram BD, which was about 0.01 milligram per kilogram per day, which was increased to 3 milligram BD when his tacrolimus level was 4.3 on POD 4. He was also on MMF 500 milligram BD, and he was discharged with Valgen and Septran. Foley and drain was removed before the patient was discharged. The transplant kidney Doppler on POD 4 was normal and did not show any collection. This transplant kidney Doppler we do as a routine for all patients on POD 4. So on POD 10, he was on TAC 3.5 milligram BD, Visalone 30 milligram OD, and MMF 500 milligram BD. From POD 14 to 17, he had mild increase in creatinine. It went up to 1.4. And since TAC was 6.9, TAC was further increased to 4 milligram BD. Despite that, the creatinine kept increasing. So empirically, he was given 875 milligram of 5e methylprednisolone over 3 days. And then he was proceeded with the renal biopsy on POD 17. But after empirical treatment with IV steroids, his creatinine came down to 1.1. Initially, we suspected a T-cell mediated rejection, but renal biopsy was not suggestive of any acute cellular or B-cell mediated rejection. So it was considered to be early cellular rejection. His creatinine maintained at 1.1 to 1.2 for the next 5 months. Valgen prophylaxis was discontinued 3 months after transplant. So in March 2025, he was on TAC 3 milligram BD, Visalone 10 milligram OD, and MMF 500 milligram BD. When he came for routine follow-up in April 2025, his creatinine was 1.6 with normal WBC and urine showing nil protein, RBC, and pus cells. So he underwent an ultrasound, which showed mild fullness of the pelvic calyceal system and upper ureter with a 6 cross 5 centimeter collection cyst, which was noted near the lower pole. So suspecting BK viremia, urine BKV was done, which was again elevated. CMV copies were also high, and TAC at this time was TAC level was 8.5 nanogram per ml. So TAC was further reduced from 3 milligram BD to 5.5 milligram per day. MMF was also reduced in view of high urine BKV copies, and Visalone was again decreased to 7.5 milligram once a day. So for this collection, the first intervention was done on 2nd April 2025 after this first ultrasound. USG guided aspiration was done. About 120 ml of the fluid was aspirated, following which the APD of the renal pelvis decreased from 9.8 millimeter to 6.4 millimeter. And the fluid, urea, and creatinine were done, which showed that it was not suggestive of any urinoma. And after aspiration, there was no residual collection. So this is his course. Uh, After aspiration, he had a complete reaccumulation of fluid when ultrasound was repeated 2 days later. But further intervention was deferred as he had leukopenia. So initially, we decided to treat the leukopenia before doing further intervention. This leukopenia resolved with treatment of CMV. So we gave him IV ganciclovir 125 milligram BD for 5 days, followed by oral valganciclovir prophylaxis. But after this leukopenia resolved and CMV was treated, his creatinine came down to 1.04 and didn't maintain at that level. Urine BKB copies also reduced. So we decided not to intervene for the lymphocyte. So this is the second ultrasound, which was repeated after treating the which was repeated after treating the CMV about 1 month after the first ultrasound. This also showed a collection, but the creatinine was stable. Patient was asymptomatic, and it was the same size. So it was decided that we will wait and watch. In August 2025, the third ultrasound was done, which also showed a mild increase in size of the collection, but there was a single collection and creatinine remained stable at 1. So he was conservatively managed again. The urine BKV also reduced and it became blood CMV became undetectable, and he continued to maintain at a creatinine of 1.2 to 1.3 till October 2025. And his immunosuppression was modified based on TAC levels, and it was gradually MMF was reintroduced after treatment of CMV, and TAC was also gradually increased based on his tacrolimus levels. In November 2025, almost 1 year post transplant, he underwent an ultrasound which showed two large well-defined collections. There was increase in size and there was multiple septations. These collections were seen compressing the kidney. So the second intervention was made, and pigtail drainage of the anterior pelvic lymphocyte was done. So in December 2025, 2 weeks after the pigtail drainage, we repeated an ultrasound in which the patient still, despite the pigtail, he still had intercommunicating loculated subcapsular collections with internal septations. So since it was persisting and the patient continued to have 150 ml per day of drain from the lymphocyte, we planned for a definitive therapy. CTKUB was done, which showed a minimal dilatation of the renal pelvis and proximal ureter, and there are two well-defined collections. This is actually a video here. There was one collection near the upper pole, and there was another collection near the lower pole of the transplant kidney. So, since he already had a pigtail for the anterior collection, he underwent a second pigtail insertion on the collection inferior to the transplant kidney on 5th of December 2025. From both the lymphocytes, he continued to have 150 ml drain per day. I'm sorry. So the patient insisted that the pigtail be removed. So the pigtail was removed on 8th of December 2025. 1 day after pigtail removal, he developed severe abdominal pain and fever, and he was admitted. At that time, WBC count was 26,000 with a creatinine of 1.8, which went up to 2.2. Urine culture sensitivity showed no growth. Since his creatinine was also increasing and he had an probably infected collection, pigtail was again inserted the next day, 9th of December. Following pigtail insertion, his creatinine came down to 1.7. So TAC again was reduced to 1.5 milligram BD. MMF was stopped. Tablet Vizolone was reduced to tablet Vizolone, which was already a 10 milligram once a day, was continued. So definitive therapy was planned, and this patient actually had a long intra-hospital stay because he had infection, persistent fever. So we could not plan any definitive therapy for more than 2 weeks. When the fever settled and his counts normalized, he underwent an open transplant kidney lymphocyte marsupialization on 23rd of December 2025. Tissue culture also showed methicillin-sensitive Staphylococcus aureus, and he received appropriate antibiotics, initially intravenous, followed by oral antibiotics for 6 weeks. The tissue which was sent for fungal culture showed no growth. This is the recent follow-up of the patient. He has a hemoglobin of 10.1 with a creatinine of 1.2, and he is currently on tacrolimus 2 milligram in the morning and 1.5 milligram at night, MMF 250 milligram twice a day, and Vizolone 10 milligram once a day. This is the entire case. I have a few slides on discussion. So the incidence of lymphocyl in the literature is about 5 to 50%, and it has been said that symptomatic lymphocyls can vary anywhere between 0.03 to 26%. The normal lymphatic drainage of the kidneys is mainly by the hilar system, and sometimes it is even contributed by the capsular system. When there is blockage of the hilar system, the capsular system takes over. So these are the risk factors. The predominant risk factors are improper ligation of lymphatic channels and medical causes. The use of immunosuppression like ATG, mTOR inhibitors, and CNIs are said to be the main causes of lymphocyl formation. And there are other causes like ABO incompatible transplants, deceased donor renal transplants, and prolonged warm ischemia time. Diuretics may also lead to formation of lymphocyl by increasing the lymph production. Any anticoagulants, if they are used in the perioperative period, they impair the sealing of lymph to the wound. This can also cause lymph accumulation. Acute rejection and chronic rejection each have their own mechanisms by which lymphocyl formation can occur. Chronic rejection causes perihilar fibrosis, thereby obstructing the lymph flow. And acute rejection causes intense local inflammatory process, increasing the lymph flow. Most lymphocyls, if they are less than 5 centimeter, are usually asymptomatic. Large anteromedial lymphocyls compress the ureter, causing graft hydroureteronephrosis and graft dysfunction. This is what happened in our patient. Sometimes compression of the bladder can result in bladder outlet obstruction. It may also present as a lymphocutaneous fistula, scrotal mass, iliac vein obstruction resulting in DVT, and ruptured lymphocyl can also cause ascites. The USG is a mainstay for diagnosis, and sometimes CT is also employed for diagnosis of lymphocyl. The surgical parts of prevention of lymphocyl, I will leave it to Dr. Deepak Raghavan to discuss. We can avoid using sirolimus in the early post-transplant period, post-operative period, and mindful use of immunosuppression. There is also evidence that placing an intraoperative drain and leaving it for the initial post-operative period reduces the lymphatic collection. Asymptomatic small lymphocyls are usually managed conservatively. Aspiration can be done for biochemical confirmation. This is usually to rule out any urinoma. Small symptomatic collections can usually be aspirated. Sometimes they reaccumulate, but if they don't reaccumulate, it can be left as such. The most common indication for treatment of lymphocyl is ureteral obstruction causing HUN. So infected or obstructing lymphocyls are usually drained externally using a closed system. Ultrasound guided percutaneous drain placement is usually done in recurrent or large collections, and sclerosant installation has a failure rate of less than 11%. But in recurrent large lymphocyls, the only way to treat them definitively is open fenestration or deroofing or marsupialization, especially if they have persistent high output. So these are the complications. These patients with the lymphocyl generally have a lower graft survival at 10 years. They also have an increased risk of rejection. Lower albumin levels also lead to increased morbidity. This is it about my case.
So are you done with your case?
Yes, sir. I'm done with my case, sir.
Yeah, just okay. And share the slide. We'll have a discussion. Okay. Very nice. Ma'am, you can now ask Dr. Deepak Raghavan to.
Yeah. First of all, thank you, the organizers, for the opportunity, and also thankful to Dr. Rajagopalan sir, my senior colleague at Apollo, who graciously agreed to share his patient, and I covered him in his absence. And coming to the patient, I think we have a patient who has a lymphocyl which was detected first as six months.
Can you please
So it is
unshare
very.
the slide. Yeah. Please unshare the slide so that yeah, please. Yeah.
Hi, sir.
Yeah, ma'am. Please go ahead, ma'am. Sorry. Okay.
Yeah. So we have a patient who has a lymphocyl which was detected at 6 months. So it is very difficult to say whether it is early onset or late onset because we never did any ultrasound prior to 6 months. So normally the picking up rate is more at 6 weeks. So probably we didn't do any ultrasound at that point of time. But also if we would have done also probably we would not have done anything about it. And also we also had a history of disease donor transplant where it is it's a emergency procedure and omentopexy was not offered. And we are not not sure about the donor surgery if the ligation of the lymphatic vessels happened well. And also we don't know about the other recipient who got benefited from the transplant. We don't have any details about him, whether he had a similar history of lymphocele or not. So our patient had a symptomatic lymphocele. Earlier he was asymptomatic, later it became symptomatic, and also he had a history of an early possible ACR, which was managed with steroids. So that could have also have triggered the possibility of lymphocele formation and persistence when the healing happened by perihilar fibrosis. Coming to the immunosuppressants, we didn't give any cyclosporin or mTOR. So normally all the patients receive ATG and MMF, so we don't know how much they are the culprits. But steroids, obviously, yes, it was high dose of steroids initially also, and also for the treatment of ACR, which could have impaired the resolution of lymphocele if it have already formed there. So also interesting part is like it's a common complication which we normally don't see much now because of the interventions and lot of surgical innovations which have come up. But the important point was all the forms of treatment was offered to our patient. So it's very important to pick it up early, judiciously manage it, and try to prevent it as far as possible. And if it is already there, it is good to treat early because we can prevent the morbidity and reduce the cost. So that's what I wanted to convey. And I now over to Dr. Deepak for his expert comments.
Hi, Deepak, please go ahead.
Thank you. Thank you so much for having me. It's a pleasure to be among a huge bunch of nephrologists. Thank you so much. Much honored. So I think my presentation is there with Dharanya. She could go ahead and share it. She's given a very, very beautiful and very short but crisp presentation. Yeah, there you go. So see, I'm not going to dwell into a lot of the causes and other things because she's gone into most of it. So it's just that I'll skip through to some of the more recent things that we do and what are the things which actually make a difference and what are the things which don't make a difference. So can we move to the next slide, please?
Tanya, keep moving.
I think,
Yes, sir.
Yeah, please.
okay.
Yeah.
So generally, a lymphocele is something which does not have, it does not have a muscular layer. So there's no way for it to compress, collapse, or push the lymphatic contents out, and they themselves don't have much of coagulating factors within it. So it's just always there. Once you get a lymphocele, it's generally always there, and there's always a lack of platelets within the lymph, which delays the resolution of all these lymphoceles. So they always tend to collect. Can we move, please?
Sir, yes, sir. I am just
Thank you.
trying.
No problem. So we have seen this. Dharanya was saying that it's anywhere between 6 to 50%, basically meaning 1 in every 4 transplants will have some kind of a lymphocele. But it's just that 1 in 20 or so only need intervention. And like most of the time, we did not do much of evaluation, or we don't do much because it takes anywhere between 6 weeks to 6 months before all these lymphocyte cavities or lymphocytes form. And it's not that everybody actually needs, it's only when the size becomes large. So even in this case, can we go to the next, please? Even in this case, it's only when it is beyond 10 centimeters that we start realizing that there is a compression on one of the adjacent structures. So one of the things is the lymphocytes compress ureters. So they cause hydronephrosis. We also know that, yes, it can cause compression of the iliac vein. So anybody with the ipsilateral DVT is always suspect for a lymphocele. One of the things is when there's a compression of a bladder, it generally lymphoceles don't track down below the prostate to cause an outlet obstruction. So outlet obstruction is not something we would give credit to for a lymphocele. It's a small volume bladder. The bladder is compressed from externally and they have a small volume. They cannot distend beyond the points. They keep voiding smaller volumes. So frequency is one of the things which would trigger us to think of a lymphocele. Next, and a larger size will cause a lot of pain. Okay, next slide, please. Thank you. So one of the risk factors that, like how Dharanya said, was age. Anybody more than 50 or anybody who is hugely obese has a higher incidence of lymphocele, or anybody where there's compression of the lymphatics. like a large polycystic kidney, they can cause lymphocyte formation. And we use a drain for everybody because non-usage of drain has been proven to have a higher incidence of lymphocyte formation. And we are always very wary of somebody having an intra-abdominal surgery before, not for any other reason, but we know that the lymphatic chain is blocked, and then they have a higher chance of lymph collection at various places. So it does not make a difference whether we do a lap donor nephrectomy, an open donor nephrectomy, whether it's a living related or a disease donor. It does not make you for a donor nephrectomy. You can use HTK, you can use UW. It does not make a difference. What makes a difference is whether we have occluded the lymphatic channels. And again, we have tried everything. We have tried ligating it meticulously with silk and then transecting the lymphatics. We have used bipolar. We have tried, and then we have ligated. It does not make a difference. Of late, there were a lot of sealing devices. We have started using harmonic scalpels to try to seal. Even that does not make a difference. As long as the edges are sealed, it does not matter what technique we use, whether you ligate it independently or you burn and cut it, or you bipolarize or you use a harmonic, it does not make a difference. And I mean, induction and maintenance protocols, that is purely a nephrological subject, which I really don't know whether it makes a difference, but I think it doesn't make a difference. So, okay, but so the whole thing is we have to prevent the formation by meticulously occluding the lymphatic vessels. The lymphatic vessels come both from the donor kidney and from the recipient. There are many times where the recipient vessels, you won't even be able to see it. So previously, we always used to say that when you do an external iliac, the lymphocyte formation is more because you tend to skeletonize the entire external iliac artery. We have gone on to doing internal iliac dissections and use the internal iliac for anastomosis. Even that, it does not make a difference of to which artery you use. But it's just that probably when we do the internal iliac, the amount of dissection of the lymphatic chains are less. So the lymphocyte formation is a bit lesser when you use the internal iliac. It's all very marginal. The only thing which makes a difference is peritoneal fenestration. So we moved from doing a treatment by peritoneal fenestration to prophylactic peritoneal fenestrations. So the treatment options can be varied depending on the sizes. You can have a percutaneous aspiration, which we tried for this guy, pigtail aspiration. There's like 60% chance they're going to recur. You can try sclerotherapy with giving povidone, iodine, tetracycline. Initial days we have tried tetracycline, we have had complications. We have had ureteric strictures itself because of the reaction. And these lymphocytes, you just have to keep instilling betadine or tetracycline week after week for 3 or 4 weeks before they actually have any lymphocyte occlusion. And it's just that by default, we will tend to use a lot of iodine. In the betadine povidone, we make it very, very concentrated. It's the reverse. Using a thinner iodine, using it more diluted is what occludes the lymphatic channel, not the thicker ones. So these are just some of the surgical aspects that I'll be covering. But again, sclerotherapy is not any great because there will be catheter slippages for 3 weeks. Those people cannot have a bath, and it's a bit of a messy thing. Lymphangiograms, lymphangiography and embolization of a lymph leak can be done only if it is a donor vessel, if it's a recipient lymphatic chain which is leaking. If it is from the donor capsule or from the hilum, you obviously embolizing a lymph vessel from the recipient's lymphatic chain is not going to help. So the best finally is if you have a lymphocyte more than 10 centimeters is operate. Whether we do it lap or open is a gold standard. Thank you. Next slide, please. So some of the things we have to realize is, see, this is the technique that we have changed now. Instead of doing a treatment, this is a paper that I have presented where we initially create a peritoneal window. You can see it in the first picture. You make a small 2 by 2 centimeter opening, pull down the omentum, and you can see in the next picture that the omentum actually is plugged. Can you move to the next please? See, you can see that the omentum is being moved, and in the next picture, you can see it is placed next to the hilum of the transplanted kidney. So this tends to reduce the lymphocyte formation because basically the omentum has a lot of lymphogenic capacity. It will just absorb all the lymph. And we do not make a huge big tear in the peritoneum because then the bowel will come in. And if the bowel comes in, it is difficult to do biopsies and other things. This technically is one of the things which has given us a lot of freedom from this lymphocyte and having to tackle it. Going in again for a lymphocele is as difficult as having to go in through the same incision. I have seen laparoscopic lymph marsupializations where you don't know where the ureter is. So we have had transections of the ureter done outside, seen that you go through a lap, you go from within the peritoneal cavity and you just transect the ureter because you don't know where the ureter is on the inner wall of the lymphocele cavity. So most of the time it is actually safer to go back open and come from outside, trace the ureter and then make a peritoneal window. So to save ourselves of all this hassle, one of the easiest is to go in and do this. So since we have started doing this, I have done maybe about 75 or 80 cases now. We have had 2 lymphocele recurrences only, or even less. So we have had only those. We have never had other complications, like having difficulty in biopsying and other things. So the biggest fear initially was if you make a big window, you will have bowel herniations. But these are all small 2-3 centimeter windows and does not increase the risk of other surgical complications. So one of the other innovations or other things that I have been doing, can we have the next slide, please? We jump to slide. Yeah. See, this is something that has been done. You can see how big this incision is. We're all aware of this hockey-shaped incision. That's a Gibson's incision. And this is what we used to do for a long time. But we have moved, or I have moved from that incision now to this midline lower abdominal incision. What happens is your exposure is as good as you go in, but there is no incisional hernia. There is no burst absorbent. And the opening is fast. The closure is even faster. And if at all you have huge obese people, there is no hernia formation because you can do component separation and other things. So midline incision actually helps when you have obese people or people who have who are very particular. The scar is much lesser than what you have. People who are long-term or second transplant, when they walk in, they have very poor muscle tone and they have bad tissue. It's better to do a midline. So these are things which actually, the incision does not change the lymphocele, but this helps in the recovery of patients. So thank you for the patient hearing. But
thanks a lot, sir, because you have given a lot of information to this discussion. Can you unshare the play? Yeah. So actually, sir, I really appreciate that the last slide which you brought in, they're quite related to the lymphocele. It's very informative for us. Sir, actually, in last 10 years, we have made it a paramedian. We never do that kind of thing. We need a musculoperitonetic, as you rightly said, exposure may not be a good problem. In fact, if you want to put it in a common iliac, probably this incision would be the best. Actually, I really appreciate that, sir. So another thing you said about the preemptive opening, and that is peritoneal window.
Correct.
Exactly, you said 80 cases you did, and another thing you rightly point out, the warning to the laparoscopic fenestration. It's a problem, big problem. You said right word about outside to inside opening, delineate the structures, and you made a beautiful few points there, which you have to be borne in mind.
So one of the things is, if you ever ask your surgeon to go in for a lymphocele marsupialization, please put a pigtail. That is life-saving. You have to have if there are 4 lymphocele cavities, have 4 pigtails. You cannot delineate because everything will be so thick that you will not know whether it is a capsule that you're going through or whether it is a thickened abscess cavity or a lymphocele cavity. So it's always better to have pigtails which you can instill, methylene blue, see it distant, and then access and convert it into a marsupialized or a fenestrated system.
Even for open, sir? Even for open?
Even for open. Because it doesn't take much to put a pigtail just before you shift it into the theater. Keep it there so that is an access.
Yeah,
it is life-saving.
Yeah. Okay, I got your points. So now I'll switch this in discussion to the respected panelists. Sir,
Sure,
Yeah.
please.
Yeah, thank you, Dr. Deepak Raghavan. A very, very
Pleasure.
well illustrated, and then your prophylactic approach of fenestration is it's very good, and it is preventive is always better than going in and treating it. It is very difficult because as we give calcineurins, they are fibrotic. So to going in and operating in that side is very, very
Yeah.
difficult.
True. I agree.
Only thing is early diagnosis, which usually we do the sonography at around before the discharge around 7th day, and then we usually our patients stay with us for 2 months. So before we send them home,
Yeah.
we do a sonography and the Doppler everything so that we're not dealing with it. That can recognize, but again,
Yeah.
it won't preclude to any of the treatment modalities won't change. Basically, because you have to treat once the creatinine goes up, or there is any hydronephrosis, or there is any vessel compression leading to an edema or other thing, then only we go and touch it. The other possible etiologies in this might be, yeah, again, you said it's a donor origin and even a recipient origin, recipient more, and donor is around contributes to around 30%. But again, the infections like CMV and BKV, which had, it also contributes to the lymphocyte formation. This patient had both CMV and also the BKV because it causes inflammation around the graft and even can cause ureteric stenosis. Similarly, it can cause lymphatic obstruction, which can predispose. So that is one of the other etiologies in this patient, in addition to the ACR he had, steroid use, and the age, which can contribute to the formation of the lymphocyte. Again, it started early, I think picked up. Again, the treatment modality, he will have to do it when one is symptomatic. Otherwise, just touching it, some of the people, they will regress also, don't require anything. We had
Correct.
now a 12-year-old transplant. We have lymph collection around the graft, but it is not causing anything. Renal function is 1.2, so you are not messing it anything because it's not easy to go in and do anything.
I agree. True.
ma'am, thanks, sir, and all your points are really valid, sir. And
Pleasure. It's a pleasure.
Yeah.
Thank you
Thank
so
you.
much. Thank you so much for having me. Thank you so
Dhanapriya
much.
ma'am, Dhanapriya ma'am.
Night presentation, Ranjini, from your team. I think we always like what where I work in government setup, the incidence of lymphosis is less. We usually go ahead with open donor nephrectomy. So what we have seen, the lymphocyte incidence less. Even if we see the treatment offer would be like intervene only when the lymphocyte is more than 6 centimeter, and usually it causes pain or obstruction or something like that. And usually first we try with aspiration, whether it resolves, or few patients we went ahead with povidone instillation. I think 1 or 2 patients we proceeded with surgical intervention. So usually what the dilemma we have in dealing this patient is that in the early post-op period, around maybe a week or 10 days, especially when we have a disease organ transplant, where they tend to stay longer with us, there will be always a collection. I mean, the routine ultrasound picks up the collections, hereditary collection. So we always have a DD in our mind, whether it's a hematoma or it could be a urinoma or lymphocyte. So usually when urinoma and hematoma occurs early, less than 2 weeks, and lymphocyte, it usually occurs, I think this more than 2 to 3 weeks. In this patient, actually, the lymphocyte is quite later. I think it's around more than
6
6
months.
months. And again,
6
I
months.
think 6 months. And again, I think sir told the CMV infection, EB infection would have maybe a precipitating factor of lymphocyte in such patients. And when we have a DDS, hematoma, urinoma, and lymphocyte, we all as we usually go ahead with even with which is less than 6 centimeter, we'll serially monitor. The radiologist will say that it looks like either a urinoma or lymphocyte. Because there is a lot of internal suppression, maybe probably a lymphocyte. It's so much of isoechoic, probably the urinoma. But again, it's very a dilemma. We tend to aspirate the fluid and send for
Biochemical
creatinine
analysis.
levels and everything to look into it. I think you have managed well, and the patient benefited with the surgical intervention. Thank you.
Yeah, thank you.
Thank you.
Thank you for the inputs.
Probably, ma'am, my view is that probably this picked up late because the routine ultrasound was not done on regular basis. Probably that is one reason. Because see, generally, when a post-transplant patient, even like, normal general examination like stethoscope, whenever they come in a week, just put ultrasound, they just a probe and see whether everything is all right. Probably this, I think that is the time lag of 6 months, probably would have developed lymphocyte much earlier.
Yes.
Probably came to notice little now when the size, because the ultrasound shows clearly, because the lymphocyte is a compressed connective tissue. It's no epithelium. So it's a wall is very, very well defined. So it's clearly cut. But adding to that point, since I'm interested in all these things, and just collections are divided into 4 types: upper pole collection, lower pole collection, and incisional collection. Incisional collection will be in the layer of incision, which will be very diffuse, curvilinear. Like that's not going to be a trouble. Upper pole collection we can easily deal. The problem is in the lower pole collection. The collection, if it is over the vessel between, sir said, Deepak Ravan said, between bladder and the lower pole, that is where it irritates the bladder. If you see below the vessels and close to the hilum, then you have to rule out aneurysm. So this is what we differentiate. Just put a Doppler and see whether the color waves going around the cyst or inside the cyst. This is hilar cyst is a dangerous cyst. So until otherwise, it's a thing you are dealing with aneurysm. This is what we differentiate. And in a hilar cyst, even though there is pseudo lymphocyte, one should not attempt blind needling. It's not recommended. And just watchful. But the problem is when it expands, it can compress the renal vein, the graft vein. So lymphocyte can create a ureteric as well as a graft because low flow system. So these are additional points. And this case gave a lot of surgical as well as medical insights, and which in the CME and BKV is quite unrelated to this. I think so. But surgical management plays a big role. And marsupialization after 1.5 years is very easy because the wall, the floor itself is a thick connective tissue. You can make a good incision because the other side of the peritoneum also would have had some kind of reactionary. So making a marsupialization may be a little easier. What Deepak sir, is it?
I agree, sir. I agree. When it is thick walled, we just have to feel lots of your way through. You have to feel it and then you integrate both. I agree with what you said, sir.
The most classical clue you gave today was the a preemptive window creation. So this we will take it as a message for every one of us, because they will prevent a lot of issues. As you said rightly, so you have done 8 cases. It does not interfere the biopsy, all these things, Richard's hernia, all these things. Because so we are very we have taken as your point as a validated one, and we'll follow in our practice.
Thank you so much. Thank you so much.
Dr. Well, sometimes we see collections around the vessel. The iliac vessel, there is some collection, but sometimes it was not causing any problem. We're not doing anything.
Yes,
it may be because of the dissection, they are having a collection which is not expanding too much. Otherwise, it may also cause an obstruction to
the physiology is because the upstream pelvic, all the lower limb and pelvic lymphatics is mostly more than the lymphatic seal, sac actually. If whatever you see around the vessels, that means the pressure is neutralized. There is no expansion. So probably that's the way we can see, sir, the encircling the lower vessels. Sometimes we see the size will be same even how many times patient comes to you. The
yes,
size,
yes, it's not increasing and causing a problem.
It's a very good prognostic sign, and you need not to interfere it. But only thing, watchful. Every ultrasound examination is very essential, and the lower limb edema sometimes can be there. It can promote a DVT also. So these kind of things we have to keep in mind. Otherwise, your discussion took us into a lot of things, ma'am. Thank you, Ranjini, ma'am.
Thank you so much.
Thank you. Thank you, Dr. Ravan, sir. We learned a lot.
Pleasure.
I'll also convey to our surgeons also.
Sure.
Pleasure.
Thank you.
Is the midline incision, sir. People, it's quite surprising.
Actually, the incisional hernia is also a problem because they take a tight stitch. Then the urine output also, the pressure effect also will be there. I think with a midline incision, you're able to suture by layer, and the hernia might be less.
Hernias are less. Compression is easy, and you can actually tuck in the kidney well inside into the right iliac fossa. So closures are easier. Incisional hernias are less.
Sometimes because of the pressure, their alignment of the kidney is also not proper. So it makes a difference when we are doing a biopsy.
True.
So midline incision, your kidney will be beyond the pelvic brim side. So medial, sir. So probably the kidney will lie in a very normal position, so that that's also good. It will never touch the pelvic brim. It will be more of an intra-abdominal organ, right? Probably it's very nice, sir. Thank you. Arun?
Thank you.
Yeah, please, Bhaiya. Don't worry, you can take extra 10 minutes. We'll allow you. Your case is very.
I'll share the slide, sir.
Yeah.
Yeah, please share.
Visible, sir?
Yeah,
Yes.
visible and you're audible.
Yes, sir. Sir, this is thanks for the opportunity for presenting again in peculiar renal transplant case, sir. So,
Our regular guest, Arun.
yes, sir. So this is a 36-year-old male who's single, who's not married, is employed, self-employed, and he hails from a middle-class family. He's O positive with 165 centimeter and 65.3 kilos, 20.4 kg per meter square is his BMI. He's a non-smoker and non-alcoholic. So he was found to have a creatinine of 1.3, 1.3 in 2008. And at the same time, he was also diagnosed to have a congenital solitary kidney. And someone told him that the kidney which you have is very good, so don't bother about the creatinine, you just keep, you be normal, so don't do anything. So slowly his symptoms went up from 2008 to 2017 as he passed. His creatinine became 2.5 and he was then started on medical management. And then he has lost a follow-up to that doctor also. So then in 2022, he came to me with pedal edema, and then when on evaluation, it was found that his creatinine was 16 and CKD stage 5. So he was started on dialysis and then thrice weekly, and right IJV was inserted initially, and then later AVF was created, and then he was registered for a cadaver donor transplant. So after 6 appearals in the cadaver donor transplant, this was the 6th time. So he came for a cadaver donor renal transplant. We couldn't do a kidney biopsy because he had a solitary kidney, and when he presented to me, there was CMD was completely lost, and there was no other genetic workup which was done pre-transplant because he was not very keen on doing it because someone had told him very clearly that it is a single kidney, it happens from birth. So his dialysis vintage, he was doing thrice weekly dialysis with left BCAVF with the 2 liters UF. No access issues, no other symptoms, native urine output of around 100 ml, and he was vaccinated with no femoral punctures. So then when he came to the disease donor transplant, the donor was a 46-year-old male from a hospital in the same city. His baseline creatinine was around 1 with normal platelet counts, a cold ischemia time of 5 hours and 16 minutes, and a kidney was transported in the ice. So pre-transplant workup, his cross-match CDC and flow were negative. As I told you, no genetic workup was done, so we don't know what is the native kidney. We concluded that it is Kakut and decided to transplant in September 25. He has received a ATG, 50 mg on POD0 and 50 mg on POD1. So the story was, he is told that he is having a kidney issue, and he was told that the best transplant for him is cadaver. Both mother and father were diabetic, so they were not willing. He had one sibling was not ready to donate. So after registration, 5 times he wanted to do the transplant, but he was 2nd and 3rd in the list. So the first one got the transplant. 2 times, 2 new patients transferred from other hospital with seniority, so they got transplanted. So 6th time, his friend had passed away, and he had gone for the funeral. And at the 5th time, I understood that he is known to one of the cardiologist, our cardiologist, and his friend was his brother. So the cardiologist is a friend of anesthetist who's working in UK. So the anesthetist told somehow this is a very good kidney, young kidney, so you please tell him. So the cardiologist called this recipient and told him, hey, person who has died, so let him go to heaven or hell, but you are going to go to heaven, so you come and do the transplant. So he was reluctant to come for the transplant. However, the cardiologist convinced him and brought him to the transplant. And the cardiologist was actually sorry for what happened after that. So intra-op findings, he had a sluggish diuresis after release of clamps. The kidney turned purple for almost 15 to 20 minutes. The graph Doppler was done at OT, which showed normal MRAs, but segmental and intralobar arteries were knocked off. So the RAs were high, and the lower pole and arcuate arteries were actually showing diastolic cutoff. So we thought the MRA is normal, so probably it is ischemia reperfusion injury, probably because of the cadaver transplant. So whenever we see a purple kidney immediately after anastomosis, our primary diagnosis as a nephrologist is either surgical issue or it is a medical issue. So medical, we think it is AMR or probably a TMA, and the graft is knocked off. So in cadaver transplant, we generally think it is a ischemia reperfusion injury or ATN, probably a severe ATN. So we do wait for things to go. So going to the post-transplant period, on post-transplant day 1, he had nil output. His creatinine went on rising. His renal Doppler showed mild raised in the main renal artery also. So the interlobar branches also there increased in RI. There was mild ascites and mild pleural effusion. On POD2, so because he was having increased fluid overload, so we started him on dialysis, and alternate days, next 4 sessions of dialysis was continued in the admission. On POD8, the Doppler was repeated. There was no hemodynamic deterioration, but the RIs had completely gone up, and there was mean renal artery also was knocked out, and absent diastolic flow in the segmental artery, interlobar artery, and arcuate arteries. So this was the Doppler, which says the main renal artery was raised and there was a diastolic cutoff. So after all this, I decided to call the other kidney, the in-house kidney, and was found that the recipient had died on day 2 there. So in-house recipient had underwent a transplant. He did not have urine output, and they couldn't do a biopsy. So I also was in the dark. So I thought probably this kidney is also gone. So next, I'll take you to the course from POD8 to POD50. On POD8, I convinced him. I spoke to the anesthetist and the UK anesthetist and told that probably we have lost the graft. So we counseled the patient, telling that the graft is gone. So you have rejection, and so probably we may need to do a nephrectomy. But however, somehow I was reluctant to do it immediately in 1 week. So I told him we'll wait for another 2 weeks. Let's see what happens, and then we will take it from there. But during the follow-up, he persistently had high creatinine, uremic symptoms, fluid overload. His HP was going down. So we continued him on hemodialysis, but he was reluctant to do dialysis in our hospital. So he went back to his old center. And somehow we passed the 2 weeks, hemoglobin hovering around 8 to 9. And then we remove in our hospital DJ stents on 21st day. And DJ stent, he was admitted for DJ stent removal. And for my luck, there was no output till then. But after DJ stent was removed, there was 300 ml urine output, which was very cloudy Coca-Cola colored urine. So at that time, I was very happy, and I saw 300 ml, and then I got a Doppler. So at the Doppler, there was reversal of the blood flow and complete absence of diastolic flow. So then I told him that, okay, we will do nephrectomy the coming week. And meanwhile, we were busy with other transplants, live transplants. So we told him that we will do it in next 10 days. And 21st to 50 days, we advised completely for graft nephrectomy. And I did have a Zoom call with the UK nephrologist, anesthetist, and then a nephrologist in UK, so his friend. So they gave me an advice that, okay, doctor, anyway, this graft is gone. So we'll do the nephrectomy and make him prepare for a second transplant. At least I'll talk to the family members. If mother is willing, we'll do a transplant. So then later what happened, he had one relative's marriage. So he went for the marriage. So he couldn't come the next 10 days for the nephrectomy. And we were also, because of the lack of evidences, we were delaying the surgery. So then what happened, he told that, sir, I want to get the nephrectomy done, because my nephrologist was also told. So let us post me for a nephrectomy. So we posted him for nephrectomy, but meanwhile, he had some financial issues. So his father told that some amount has to come from somewhere. So he delayed that surgery. We admitted him, and then he told, sir, no, I'll come next week and get admitted. And he got discharged. So this was also a blessing in disguise. He went. So we advised in between of all the possible treatments, that is plasmapheresis, increasing the immunosuppression. But he was very convinced with the UK nephrologist. So he told, sir, he doesn't want to do anything else other than taking the triple immunosuppression, maintaining a TAC level. We were maintaining a TAC level. He said, strictly told no to a plasmapheresis, because the UK nephrologist had advised him that if you do plasmapheresis in India, there will be a lot of infection and you may end up with complications. So with all these pertaining things, we retained the graft. So absent diastolic flow for almost 50 days. So ATN, rejection. And we had evidence that there was rejection also. So I had done a graft biopsy on POD5, because till 5 days, I thought it is ATN, but every day the Dopplers were becoming bad. So I thought we'll do a biopsy. The biopsy on POD5 showed acute cell-mediated rejection, class 2A. What we have to see is the vascular V1 was there and the C4D was negative. So it was reported as acute vascular rejection with acute T-cell mediated rejection, class 2A. And then I did another biopsy on 7 because there was a diastolic reversal on day 7, and then I thought probably it's an AMR. So we have lost the graft, probably it's a TMA. So same thing, there was a ACMR with class 2A and comparatively poor perfusion was noted in the upper pole. So I thought probably the upper pole is going for a completely necrosis or probably a focal damage. But however, after this evidence on 50th day, there was that 300 ml output and there was some stabilization of creatinine. I called him and did one more biopsy. So on POD 50, that was showing mild ATN. So now all the rejection had vanished from the biopsy and it was only ATN which was there. So the biopsy findings were very clear and evident that it was ACMR class 2A. There was a DSA positivity which I had done and C4D was negative. So I concluded that it is probably a rejection which worsened. So he had a congenital solitary kidney. We don't know what was the native kidney disease. He did not have any hydronephrosis or any other features. He underwent a disease donor transplant, kidney turned purple with altered renal Doppler parameters, worsening renal function, dialysis dependence for 50 days, biopsy features showing ACMR class 2A and up to POD 50. DSA was also positive and C4D was negative. So I thought it is ischemia reperfusion injury, ACMR plus C4D negativity. Putting all things in perspective, I thought it is a rejection, AMR, probably the graft is gone for a toss. So what we did, we used repeated Dopplers. We did supportive bridging therapy. We never stopped the immunosuppression because even though the nephrologist from UK advised me to stop, I told, sir, let us continue till the nephrectomy and then we will reduce it. So we supported him dialytically and hemodynamically we kept him on observation, maintained his immunosuppressions, and we went on emotionally supporting him and telling him that miracle can happen. Sometimes it has happened. So emotionally we didn't abandon the graft. So what could be the problem? So initially we thought it's a plumbing problem, probably a renal artery stenosis which was not there. Renal vein thrombosis was not there. Anastomotic technical issue was not there. There was no external compression, hematoma, or compartment-like effects. So perfusion problems, yes, he did have. There was no intraoperative hypotension. There was no vasopressors. So he had ischemia reperfusion injury. He had probably a severe vasospasm. Prolonged warm ischemia time was not there. So the other half was, there was probably a parenchymal injury, which was probably severe ATN and a delayed graft function. Cortical ischemic injury was not clearly evident. There was no TMA. There was patchy infarction at the upper pole, probably, and donor quality was very good of the donor. But there was the in-house kidney had failed and probably the patient had died. But we didn't know why he didn't have urine output. So immunological problems, as you know, there was mixed rejection. So at what point do you continue to keep patients and at what point do you declare the kidney non-salvageable? This was a big question which I couldn't answer, and it was good that I didn't answer. So what all are the recent advances that we can see in early graft dysfunction and what we can do? So normothermic machine perfusion and advanced ex vivo perfusion system, which says that it is very, very good where if you're doing a cadaver transplant, this helps in maintaining the graft for longer periods. And it helps in maintaining the graft not only in protection of the ischemia reperfusion injury, it also helps in reduction of rejections, which is possible because of the ischemia reperfusion injury. Then you have contrast enhanced ultrasonography for graft microperfusions, which clearly tells you what happens in the micro level, at the microvascular level. Is there a damage? Is there a perfusion issue or it is a rejection issue? And there is continuous optical perfusion monitoring or near infrared spectroscopies, which helps you and predict what happens to the graft, whether it is a rejection, whether it is IRIs. You also have a donor-derived cell-free DNA and molecular diagnostic techniques, which we use MMDX, which is also powered with AI now and helps in identifying whether it is a rejection, injury, or whether it is salvageable, non-salvageable. So here what happened, why did the kidney recover after 54 days? This is a hypothesis. A vascular rejection does not always destroy the graft. If you diagnose it early, your treatment is aggressive, there is no vascular thrombosis. So slowly, once the immune injury is treated, that is, it reduces inflammation, microcirculation recovers, and tubules regenerate. And ATN may take at least 4 to 8 weeks to recover. Severe ischemia or ATN or vascular TCMRs with delayed recovery, both of that combination, that rare combination, but it can cause delay in recovery and recognition that the graft can recover even late. So what is unique in this case? One, there was purple kidney. I saw the kidney very purple for the first time. Absent diastolic flow. We did dialysis after transplant, biopsy showing rejection, ATN, which took 4 to 8 weeks to recover, and complete recovery after 2 months. So I usually trade. So recently, 1 month back, I had seen the silver and the gold prices fall like this. So my heart was actually paining when I saw the silver price fall, but at the same time, his creatinine also fell. So this was a very happy graph for me, where you saw the creatinine had gone up to almost 10 and he was on dialysis. Always it was used to be around 7 and 8. And then rapidly one night he called me and told, doctor, I have 1,200 ml output on 54th day. I was shocked. I told him for 1 week. He told me, no, sir, for last night. So I was so happy, and I called him the next day morning to come to hospital, and we did a Doppler. The Doppler was completely normal. So from that day, his creatinine started going down, and now it is around 1.5. This is baseline creatinine now, and he's on triple immunosuppression. So there are many studies which have done and shown that the graft can work slower. This is one Sis et al., American Journal of Transplant, and Laupi et al., which is published in AJT. In all of them, they say that at 4 to 8 weeks, there is chances that the graft can be severe, have a ischemia reperfusion injury, endothelial activation. There is microvascular inflammation, immune injury, both AMR and TCMR, and prolonged delayed graft function, and gradual tubular regeneration and recovery. And most of these say it is 4 to 8 weeks. So as I told you here, the diagnosis was ischemia reperfusion injury, vascular T cell and antibody mediated microvascular injury. As we all know, there is post-pregnancy, there is Sacco-Subo cardiomyopathy, stunning of the heart. Here probably the kidney has stunned, and what we call the stunning kidney, not destroyed kidney. So the interaction will be on these 3 things probably: the purple kidney, absent diastolic flow, and when do you label a graft non-salvageable. So the fight continued for nearly 2 months, and the graft appeared silent. Doppler distressed, biopsy showed immune injury, dialysis required, yet the kidney had not failed. It was temporarily stunned by ischemia and immune activation. Once the inflammatory storm settled and tubules regenerated, the graft slowly awakened. And he is having a normal kidney, off dialysis. His creatinine is now 1.5. He's on triple immunosuppression. And every time when he comes, his creatinine comes down by 0.1, 0.2. So I told him that if your baseline creatinine is 1.8, we have achieved everything. And whenever he comes, he laughs and asks me, sir, now my creatinine is 1.52. What do you think? So I tell probably it is double dhamaka. And God has been kind. And the cardiologist is the most relieved person after 50 days, because he was the one who called him from the funeral and got him transplanted. And now whenever I talk to him, he laughs and tells that I had convinced that family so much to get transplanted. So everything looks worthwhile. So waiting for long has actually helped this patient. So probably we need to be very careful when we decide that this kidney is not salvageable. Kidney is a very hardworking organ. So sometimes we may get the fruit at the last point when we think everything is over. Thank you for your patient listening, sir.
Thank you, Arun. Thank you. Excellent, and congratulations for your patient and yourself. So please unshare, and ma'am, we quickly invite Sir Umapati sir and ma'am.
Yeah, Dr. Arun, very happy ending. It's
Yes,
an Arunodaya to everyone that don't lose your
Arun, unshare the
ambitions
slide, Arun.
how do you answer?
So basically, you have done a first a biopsy. It was showing an ABMR. Whether it's an anti-endothelial antibody, whether it was that, it can behave similarly. Like immediately, it can cause there is an injury which has happened because of the reperfusion. The small amount of anti-endothelial antibody similarly behaves like an ABMR-like situation. I don't know why other patient had lost his life. I really don't know. But there was something which was there. I really don't know. But again, the second was showing an ACR. So the inflammation was slightly less. The third, which you did at 50 days, only ATN. So with ATN, I don't think we cannot take out the kidney. So there is still a hope, which you explained the patient, and also you kept your patients, and then the patient had a better outcome. So usually what we wait with for 2 months to usually we wait it, and there is no antibody. And if there is any total, if there is any cortical necrosis, then we don't keep it for more than 2 months or 3 months. Then we take accept it as an early graft failure and then take it out. Otherwise, unnecessarily he'll have to take an immunosuppression, and it will create a problem in the long run. So but the biopsy did not show any significant patchy cortical necrosis. So there was something, and it was delayed healing or ATN recovery, the ABMR, ACR, which was you treated. So it was improving, and it took a lot of time for ATN recovery possibly. Again, very, very good case that we should not, early hasty decisions of nephrectomy should not be done. I think till you have no ending, like there's a complete necrosis, we should not stop the immunosuppression completely. Otherwise, they may have a rejection again, and there will be no point of returns.
So many things which I didn't tell in the slide is every time when he used to come, he used to ask me, sir, immunosuppression. He would read everything in Google, and then he would come back and ask me, sir, we should have stopped this medicine, that medicine. I told, okay, we'll stop all the medicines at one shot. Then there was another nephrologist also involved, so from UK. So he used to send messages to him, and then last, after all this, he shared those messages to me.
You have done a wonderful job. You have not stopped the immunosuppression is good. Otherwise, he may have a graft dysfunction because of the ABMR and then graft rupture. So because ATN was there, so it is recovering. You stop it, there is an HLA antibody expression, so he will develop antibodies and he will have a graft syndrome. So you have done a wonderful job. You have kept your calcineurins and also this thing, that is good. Otherwise, the recovery, because calcineurins are the main role. So he was not getting any graft pain, nothing. So you have kept your head cool and worked it with very good.
Thank you, sir.
Please go ahead. Dhanapriya ma'am.
Yes, Dr. Arun, it was a very wonderful presentation. Like listening to a presentation is like seeing a thriller movie. I was really scared. What will be the end? The thing was that when the kidney turned purplish, we will always have a dilemma whether to keep the kidney. We actually have come across in 2 or 3 DDRT patients whether when we release the clamp, the kidney will be purplish. So we always ask the surgeon to look into the vascular intactability. So is there any kinking like that, or any compromise in the vasculature? The vasculature compromise is not there. Maybe but still we have dilemma. I think on one patient we went ahead with nephrectomy, and it was like a rejection. It was an acute rejection. And still, I just want to ask the other chairpersons, how to go about with the purplish kidney, whether how safe is to keep the kidneys, and what about the implant biopsy, whether we could have went ahead with the implant biopsy so that whether to look into the rejection and something like that. And my second question is that though the biopsy was done in day 5, it showed some kind of rejection, and it was not, I think it was not treated with plasmapheresis or any steroid therapy, right?
We are given regular routine, whatever we used to do, we did.
But anyway, the day 5
And the 32nd, ma'am,
biopsy showed some kind of cellular rejection.
It was vascular rejection. When I spoke to Mahesh sir, he told it is vascular rejection predominantly. I'm giving it as ACMR, but it predominantly looks like vascular rejection because there is a lot of infiltrates around the vasculature. And so we explained it to the patient, madam. He was completely telling no to plasmapheresis. So we have just added extra dose of steroid and then just left it like that. And he was very clear.
But he was not given any pulse therapy, something like that.
Nothing. He is not given because the patient denied plasmapheresis.
Plasmapheresis.
But because Arun has fixed in mind this kidney is gone, and he was
Yes, sir.
contemplating a nephrectomy.
Correct, sir.
Unfortunately, the delay was done by the nature, by the patient's decision, other things.
Yes, yes.
So you
It is
should
a destiny,
ask your
sir.
patient, Arun.
It's a destiny. I think implantation
Definitely,
biopsy could have been explained and it could have shown what is exactly happening there. So
Ma'am, to
usually
answer
in
your
our
query,
case, what we do is first we'll check the vascularity. Sometimes if the flow is a poorer, then they do redo anastomosis by reflush, and then they do the redo anastomosis. So otherwise, if there is again the purpleness, if there remains and there is no output, we take an implant biopsy. And
What
then we know
okay. What was the cause of death in the recipient who received the paired
that's
kidney,
So
another kidney?
that we didn't know, madam. He had sepsis. They told he after the transplant. I think he also did not have urine output, but the kidney did not become purple there. But the kidney was normal. Some few drops of urine came. So they thought it is probably disease.
what was the urine output in the donor before
He didn't have,
the removal of the kidney?
sir, he didn't have urine out. Means in the donor, sir.
Yeah,
Donor was having good urine output, sir. Around I
Okay,
think
okay.
75 to 100 ml output was there, sir. And he
Ma'am,
was a young chap, sir. The
to
donor was a
answer
very
your
young
query,
chap.
ma'am, how to identify the purplish kidney on table? Because end of the day, we get a kidney and we all get frustrated. Surgeon wants, the entire team wants to go home. They don't want to be, bedside for another 30 minutes, 40 minutes. The first thing is we have to wait and watch. That's the one thing we can go ahead. Whether the kidney become the bluish, become the island of blue, or become a pinkish. That's the one way we can do it. And the pole to pole, the consistency. If it is a very flabby, soft, and moth-eaten like,
Won't
then
recover.
it's gone. That kidney is gone. And people, the surgeon used to palpate the artery and say that there's some kind of pulse is there and rest of. But the best thing is you have to use the intraoperative Doppler. Doppler will give you a good clue. If it is only systolic spike, small spike, that kidney is gone. If you have a good spike and some kind of wide base systolic with the diastolic cutoff, we can accept it. So now, see, nowadays we are using a pencil Doppler, man. Pencil Doppler. Scientific surgeons are using. I bought it purposely for this. Any occasion comes, if you use a pencil Doppler across the vessel, that flow will give you whether this kidney can be kept, inside. Otherwise, sometimes a very frail patients, in a cadaver transplant like patients, if you keep the kidney, that will produce a acute intolerance. Patient will go for a DIC and the patient will die. So the decision should be on table properly, and intraoperative Doppler will give a good clue, with peace of mind. And thing is context, how the patient has come out, which source the kidney has come out, the surgeon's ability, recipient's nature, and cardiac function, and whatever things will all give a collaborative idea that whether this kidney kept it. But this case, a lot of paradox. Arun's case. One thing is, patient is stable. All along, patient 50 days, he's just coming for dialysis. He was taking his decision. So that stability also indicates only ATN. So this kind of things we can presume in our mind. Or anyway, it's lucky, you're lucky, and patient.
Doctor, well, when he had an ABMR like presentation, if the patient has agreed, if he had underwent up 2-3 sessions of 4 sessions of plasmapheresis, whether it could have improved the early recovery chances.
Maybe, sir. Maybe,
Sir,
sir.
maybe he could have helped, sir.
Yeah.
But at the same time, sir,
Because we can't go against the patient's will and do it because somebody is telling him that the plasmapheresis also creates problem. But again, it also saves lives.
Sir, as well, sir told, sir, we are all decided that the graft is gone, sir.
Okay.
We had all decided, so we didn't want to push him onto plasmapheresis.
Similar thing happened for us also.
Yes, sir.
So we as an ADP KD underwent a transplant, and there was a lymphocyte. Sorry, there was a collection which is happening. There are some, we are thinking that the drain, but there is a urinoma. And then he started having passing urine, the ATN recovered, and he was on a ureterostomy. He was doing well for almost for 2 years. So it's sometimes the ATN recovery, it's take time. There was a ureteric necrosis and we had to pull it out, and then he had only because the other surgery was difficult. So he was on a ureterostomy. Urine was coming. So earlier also we are doing a dialysis saying that there is no recovery. The biopsy was showing an ATN, but again, it is not recovering almost 4 weeks. We were also frustrated at what is happening, but it was the collection and that was coming out. So the urine, it showed that the creatinine was high, and the only thing is the glomeruli which concentrate the creatinine. So So he came out. It's an ADPKD, and he has very poor
Arun, another
malnutrition was
point,
there.
what I observed, because even I had seen on-table acute rejection, losing the graft, the decision is very difficult to remove the kidney on table and facing the attenders and other things.
Yes,
The
yes.
whole team is demoralized. What I
Correct.
found, the two ways of it. One, because reality is reality. We have to accept and face the people and the situation, right? Biology will never obey your commands, right? So the thing is, the kidney becomes the size of a 10 centimeter with a 5 centimeter. Once you transplant, the kidney goes into very soft and very, collapsed. This is a very gone kidney.
Floppy.
The other extreme also, the kidney becomes so turgid,
Turgid, yes.
unusual of, with the
Turgid.
discoloration. This is also bad, because probably the even
Possibly venous obstruction.
yeah, maybe
Venous.
intra-arterial obstruction is causing
Yes.
flow. And the first one is the typical TMA-like things. The second one is the maybe venous venules will becoming going for thrombosis. This is the two ways I observed, and this on-table decision is very important. This is what.
Dr. Well,
Hi, sir.
one comment.
So just to add Dhanapriya madam's this thing, sir, what we
Somebody was.
Vilas here.
Hi, Vilas. I'm sorry. Okay, please
The
go ahead.
third condition where the kidney can get tense is, which I have come recently. Our urologist, while trying to stop the bleeding, had clamped the ureter and the kidney had become super tense.
Come again, Mr.
The
Vilas.
ureteric clamping.
Ureter was clamped at the hilum, partly. And the patient was not having urine output, and the kidney was getting tense and tense. He was telling me, see, look at the.
But
look
you
at the
get a
firmness, it is
hydronephrosis,
so
no?
good.
But
Vilas, you
Vilas-
get a hydronephrosis there.
But
Vilas,
Here,
that-
there was no hydronephrosis.
wait a minute, unless we do a Doppler, we will
I know that
not
you
find
shared
hydronephrosis, right?
all the information in the group, and we know we were just at the end, other end.
The similar situation happened to me also, because there is a ureteric clot which used to happen in a patient who's diabetic, and the RI is 0.6. In 2 hours, he get a hematuria, and slowly it goes up to 0.8 and 1, and the sudden drop in the urine output.
No, this happened on the table. And we did a on-table Doppler. We noted hydronephrosis in the kidney, and just the ureteric clamp was taken up, and there was a gush of urine output. We
Right.
saved
The
our day
early
on table.
hydronephrosis, you don't get it. So
The
it
point
takes
you are
time.
trying to make is, I think we should have a dedicated Doppler machine inside the OT. This is
Absolutely.
what even
Absolutely.
high volume center who invested the crores in other infrastructure.
Right.
Not planning to buy our simple ultrasound, which we can just one single probe, convex probe, and if start using it more and more, that will give a piece
No,
of.
sir. Before closing, then the surgeon has to see
Absolutely, that is very important.
the vascularity. Before that, you should not close it.
Exactly, sir.
If he is not satisfied, you can open it. No problem. We have kept one of the vessel injury. We kept it open for a day and then did it. So you have to have a perfusion should be good. If there is no urine output, you can re-go, and then if you want to do a reanastomosis, we can do it. So it has to be there. Then only you can get a good outcome.
Anything you want to do, it should be inside the theater before patient
Yes.
shifted to the KTR. So thing is, you can see the CMD, corticomedullary differentiation, color flow, spectral pattern, all can be delineated, and it can be documented ethically also. I mean, for medical legally also. So that's very informative and ongoing clinical practice. You can apply the same thing on. So this is what I insist inside the Doppler. You see, moment you saw the purplish kidney, I would have gone for the Doppler. Good documentation of the Doppler. Whether that will give me glue. Actually, vascular rejection can be detected, just stump flow, small spikes will be there. That is a very negative sign. If you even this purplish graft, you see a good flow, I'm confident. Oh, this kidney is viable, because as you said rightly, kidney is a very resilient organ, which will withstand all insult, and it defies all biological expectation what you imply on the patient. So I think you are lucky. This patient's a good.
Thank you. We are also blessed with we have a separate.
So there are few non-textbook things which we have observed practically, sir. I have observed practically.
Yeah, please go ahead.
Anesthetic causes, sir, for having purple kidney on table, sir. So if they use induction high dose, they use morphine, and when at the release of clamps, if your BP is around 130, 120, the kidney will become purple, sir.
Purple.
Yes, sir. So this is anesthetic cause of this thing, which is not given in the textbook, sir.
But we don't use morphine, we don't use morphine nowadays, right?
So no, sir, but there are some senior anesthetists who use, sir, for induction.
Okay.
So I have had problem in identifying, sir.
From where they'll get it? Usually, You have to fill the forms and then only you can get it
Not
morphine.
that every
Otherwise, it's not
hospital,
feasible.
every
Anesthesia hospital
ICU,
will get, sir.
ICU and theater they'll be having, sir. The problem, are you doing with general anesthesia or epidural?
Sir, general only, sir.
Okay.
So
So in
what
general,
happens is I couldn't identify, sir. Many a times I was thinking there was something wrong in the graft or vasculature and something like that. And then later on we found out that immense induction with and also giving morphine, it produces severe vasospasm and also reduces the vasculature, sir. Means it produces hypertension.
people are using fentanyl and propofol. I think nobody's using nowadays. I think probably
You're all using propofol.
So the old anesthetist, sir. If you're a senior anesthetist,
yeah, it's a good point. Whatever the point you are making, it's all practical. So
yes,
Yeah,
sir.
Arun, there is a paper, even an ATG. It causes, if there is a platelet drop and everything, it
Yes.
increases the platelet aggregation.
Correct.
Okay, and that is one thing which can cause a platelet aggregation similar to an HUS or a TTP. You can have a reduced things and we can have it. I had a patient, my friend referred it for a delayed rejections. I thought I gave MP, it improved because it's a delayed rejection. Only MP don't work because he has already treated 2 times. I gave an ATG. Suddenly he had a reduction in the platelet, LGH wrote like it's typical HUS. Then I had to do plasmapheresis and everything. Then he improved. But that is also, and there is one a paper which is there, which is showing platelet aggregability, it increases, which can also contribute to it when there is an endothelial dysfunction because of the reperfusion.
fine, sir. Good point, sir. So if everyone agrees, we can wind up. It's a beautiful discussion, very interesting cases. And your case, Arun, the clinical medicine, especially renal medicine, teaches us humility in life. We have to bow to the nature. We have to, trust in God and everything. See, time delayed and his decision delayed the good outcome for you, right?
Very important, sir.
All your efforts come into fruition because of your purposeful waiting. Somehow God delayed the nephrectomy because you are ready to do a nephrectomy. So this is a lesson, as sir also rightly
So
said.
54 that he had a good sound sleep.
Yeah. So we had to wait 2 months, come what may, except in a few situations where graft intolerance happens, DAC happening. Otherwise, we have to wait with quote unquote at least 50% of the immunosuppression on. So that is a good lesson we learned from today's from your discussion. Despite the other end, the surgeon, the physician was asking to stop the medication. You continued with immunosuppression. That's a good thing you've done, and all ended well. So as you rightly said at the beginning, the delay is not ended his story. It has created a new chapter in his life. So with this, I conclude. I thank you and Dharanya for the beautiful presentation. We learned a lot today, and the contribution by ma'am and Umapati sir and Deepak Raghavan. He gave a beautiful message. And Ranjini ma'am, you ably supported your student, and we had a wonderful time today. Deepak Raghavan sir, we go with the good news today. Okay, are you there
sir.
still? I'm very wondering. Okay.
I'm still here.
Thank you very much.
Thank you so much. Thank you so much.
How do you feel about this event, sir? So,
It's very informative, very nice discussion. It's a very healthy discussion.
yeah.
I think we can ask sir's opinion what he will do when we get a purple kidney. So that's also
Fair point. Okay, I can give you a lot of surgical inputs. See, there were a few things. One is when you said that there could be a renal artery kinking. Now, renal artery kink when it causes a low flow. See, one of the things we do, okay, we will always try to match your spatulate and match the renal vessels. One thing that I've always done is I have flooded the graft site with warm water for about 20 minutes post-transplant, post-release of clamps. What tends to happen is the kidney then becomes a bit buoyant. It goes up. So when it does go up, the stretch that the kink that is there between the internal iliac and the internal iliac and the renal artery tends to straighten up. So when that happens and your vein straightens up because the kidney is buoyant, the flow is better. If post that you wait for 20 minutes and then decide to put the kidney back, like how sir was saying, before you close, you will have to look at the color. If the color then turns dark again, it means that there's a kink. Otherwise, there is no kink. If that 20 minutes and then you put it back inside, there will be, if the color is good, there cannot be a kink because
Sorry to interrupt. You mean to say that after the clamp release, you put a warm water, wait for 20 minutes?
yes.
Yeah.
See, these are things which, see, the kidney otherwise will plonk down by its own sheer weight. Once you release the clamps, it goes down, it slips down. So you make it more buoyant. You flood the system with water, you flood that entire area with water, with warm water, and let it rise up. So there is an automatic stretch or the kink, that vessel becomes straightened up, both the inflow and the outflow. So what happens is there is no more kinking. It is, that question in your mind of a kink, whether you have to redo the anastomosis, goes out. If at the end of 20 minutes you say you're done and you put the kidney back, into the right iliac fossa, before closure of the kidney becomes, blue, for sure there is a kink. For sure there is some vascularity, which or flow, which is not happening. Then you have to open, or you have to relook, or you have to accept that the artery length is too long. See, the kink occurs when the internal iliac artery length is far too long, and you've got probably a right kidney or right cadaver kidney where you have a long arterial length. Sorry, a left cadaver kidney where you have a long arterial length. So then you have
snapback phenomenon. We call it a snapback. Okay.
So that is one. Some of the other things that we have seen in cadaver kidneys which come through, especially when we do a lot, is people who have had RPS. We have had these biopsies, and they can have myoglobinuria. So post RTA, most of the patients we see now are CVA who are getting into organ donation. Post RTA young people can have myoglobinuria, and we have quite a few cases where we have done biopsies on table. We didn't know what was happening. They said hemosiderin, didn't know whether there was ongoing hemolysis. Then you start seeing, okay, this could possibly be myoglobinuria. Pink kidneys, I haven't come across morphine. Luckily, our anesthetists are a bit younger, should I say. They have not been using morphine, but yes, we do get a lot of morphine that we can use in intra-op. But the flow in the internal line, the external iliac is more direct. So the external iliac flow generally does not lead to kinking. One of the things is when we do an anastomosis, the punch that we use should be more laterally placed on the external iliac. Because when you lie the kidney down, you cannot have a punch which is straight up and then a bend. So the surgeon has to be sure that the punch that is used on the external iliac artery is a little more rotated outwards, so that the kidney lies flat, and then you don't have this kinky shape. That is one of the common problems that we've seen in newer surgeons or youngsters who decided to do an external iliac.
Totally good point, sir. Absolutely good point. Because when you apply a clamp, we don't know where the twist is there. So
yes, you have to place it more laterally.
Once you remove the Satinski, the kidney will be, we have seen some.
So internal iliac in that way is far easier because you can then rotate and put the kidney back into the iliac fossa. Yeah, but it's an absolute must that before you close, you have to see the turgidity. You have to see the color first. Turgidity of the kidney. If the kidney is sort of soft, one of the things that any surgeon or people, what I would do is I would put my hand on the renal vein, compress the renal vein, and wait and see if the kidney starts to balloon up. If it does, then you know that it's a good continuity, everything is there, and the flow. You know that he's probably hypovolemic because obviously we would have dried him up well, and we've not given enough fluid. And pre-operative, we would have dialyzed him, or if he's coming in for a cadaver, we would have dialyzed him again just before the surgery. So he's dry. Give him some more fluid. So those are kidneys we know which will open up when we are shifting them out into once we close and shift, they will open up. Compression, very light compression on the renal vein, the kidney starts to balloon up a bit. Yes, you know that the integrity of the entire system is there. As for your points, a color Doppler, that is life-saving. We have a drop-in probe, but then that drop-in probe we use more for the robo. For real-time, in-time, I have used the regular curved single probe, put a Doppler, see what is happening. That helps us know that there is a flow along the artery good enough to perfuse. That documentation basically saves our skin in a medical legal setup.
Yes, understood.
It does save your skin. The second thing is everybody in the theater is more reassured that there's no compromise in the flow. So this kind of
Yeah,
Blame
exactly.
game never occurs. You never have to tell the surgeon, boss, go in again. One thing, most of the time, kinkings occur only when you try to reposition the artery mechanically. If you leave it as it lies, it will not kink. If the lengths are good, if it's too long, it will kink. So you should have just about the right length of the internal iliac artery and the renal artery. Kinks don't occur.
I think your experience speaks volumes about this problem. Issues. I'm
Yes.
very thankful to you. You opened
We
up.
had even a hypothermia predisposes to the late urine output. So
Yes.
that you said you put a warm water. I think that
Always.
will be better, that it will improve
Sir,
your
we routinely do it, sir. But as Deepak said,
Yeah.
we don't put it 20 minutes. We put it for 4 to 5 minutes. Very,
20 minutes by the clock, sir.
tolerable to the finger, sir. Over the glove, we feel such kind of a very hot water we'll put. So that we do routinely, sir.
20 minutes by the clock, because one of the things, the moment you release the clamps and you then say, let's finish the ureter fast, I want to get out, you tend to move the kidney a lot, intrarenal spasms will occur. So then everybody starts saying, what did you do and why? So it's better to leave the kidney to perfuse, let it happen, let your tachycardia settle up. Every cramp release will lead to a surgical tachycardia. So let your own tachycardia settle down, sit back, relax, chat with people in the theater. It leaves it. I have seen that the graft tends to behave itself better.
Yeah.
And 20 minutes it does not matter much. Closing, going, coming back again to reopen is not the greatest of events to occur. So give 20 minutes and then do the bladder. One of the things that Dr. Arun was saying, he's seen a large kidney is when you over distend the bladder. So you might have an assistant who is filling the bladder. You put a ureteroneocystostomy. When you fill the bladder, we have had compression of the iliac vein and the renal vein itself. When you have a longish vein and you aggressively fill the bladder, they compress. So the bleeding occurs then. So never allow your assistant to over distend the bladder. Because once you open the bladder, that is gone. That is also one of the reasons when you have a full turgid, overly turgid kidney, because compression of the vein.
One thing, sir, when a patient is on long time vintage on dialysis, distending bladder is very inimical to the thing. That's very important.
It can rupture.
Just to partially fill the bladder and open the bladder and do anastomosis. That we learned, sir. So we have to ask, so surgeon, you are very particular about this. I'm very thankful to you, everything, because most of the time we'll miss this point and we'll over distend the post-operative hematuria. That's a big trouble. So anyhow, but it's a good discussion, a healthy discussion. So thankful.
Thank you so much, sir.
Thank you so much.
I think the crowd is also becoming thin.